Hi guys, welcome back to BroMed Lectures. In this video, we're going to cover hypothyroidism. So in this video, we're going to review hypothyroidism as a whole, not for any specific cause. We're going to make another video for thyroiditis, so review that video in regards to those diseases. But for this one's going to be hypothyroidism. Let's begin with the etiologies. The most common causes are usually primary due to the gland dysfunctioning. And the most common cause is obviously going to be Hashimoto in the United States and in developed countries. Usually considered an autoimmune condition. This is your number one cause. And iodine deficiency is commonly mentioned, but usually for developing countries. Not commonly seen nowadays, but it can appear as a cause. Secondary, usually due to post-ablative surgery or radioactive iodine. This is usually in the patient that has an hyperthyroid state or a cancer in the thyroid gland. They remove the gland. Now these patients are dependent on levothyroxine. Genetic defects seen in the patient that has congenital hypothyroidism. And these patients usually have defects on the formation of thyroid hormones, or they have a peripherally non-response to these hormones. The drugs, these are usually tested. Remember lithium with hyperthyroidism, also associated. These patients have bipolar disorder. Amiodarone, this is a more common cause for hyper and hypothyroid states. The reason behind it is amiodarone is around 40 to 50% iodine, and so it can alter the functioning of the gland. It can also develop into a thyroiditis, but amiodarone is usually tested. Sulfonamides are associated, and interferon, as we saw also with hyperthyroid states. Now, secondary and tertiary are secondary usually due to hypopituitarism, as we reviewed in the pan-hypopit video, and tertiary usually due to hypothalamic hypofunctioning. And now we're going to make a parenthesis in here for congenital. We're going to go in depth for this disease because it is usually tested and has some different causes and some different pathologies. So 85% of these patients are going to be due to either a dysgenesis of the gland or an ectopic gland. This is alteration in the formation of the gland or in migration of these cells where they should be located. This is 85% of these patients are going to be due to these causes. 10 to 50% are going to be due to hormogenesis defects, as we mentioned with the genetic defects in here. But there's also maternal hypothyroidism related. Usually the patient has the pregnant patient has hypothyroidism before the pregnancy and is not well controlled during the pregnancy, during the first trimester. Then these patients can develop congenital signs and symptoms. Low iodine in some underdeveloped countries. This one, Hashimoto, we usually see Hashimoto in patients of reproductive age, but it can appear also in children. Have that in mind. Now, neck radiation, only if the patient has this exposure. Remember, the thyroid gland is super responsive to radiation. Consider this etiology. Now, the pathogenesis being the brain requires thyroid hormone during the first year of life. If the patient is not getting enough thyroid hormone, they're going to develop these signs and symptoms. So there's going to be severe mental impairment for these patients. These patients can also be overweight, and they usually are short in stature. And now in newborns, you're going to see the following. This is a patient that has hyperbilirubinemia. There's alterations of the bilirubin not being properly conjugated. Delayed stooling in the first hours of life. Patients also develop feeding difficulties. And there's also some other specific findings such as macroglossia, bradycardia, and this one, umbilical hernia, usually developing in the first months of life. So that's going to be for congenital and for the etiologies of hypothyroidism in general. Okay, so let's continue with the pathogenesis. Please review the thyroiditis video. In this one, we go in depth for the Hashimoto thyroiditis, which is the one that we require for this condition. And for the signs and symptoms, remember that the patients are going to describe they have low energy or lethargy, constipation, cold intolerance. Some may refer menstrual abnormalities. Remember, these appears either in hyperthyroidism and in hypothyroidism. As low intellectual and motor activity, patients usually describe weight gain, hoarse voice, proximal muscle myopathy. Remember to check the creatine kinase. It's going to be elevated and differentiated from other myopathies. Delayed deep tendon reflexes, and these patients usually develop diastolic hypertension, which is different from the hypertension in hyperthyroidism, which is systolic. The reason behind this one being diastolic is because you don't have thyroid hormones, then you don't have a beta adrenergic response in vessels, and you have an alpha response taking place. The reason behind it being diastolic is this pathophysiologic caveat. Now, the patients may have bradycardia and they have carotene altered metabolism. Now, for the Hashimoto, specific symptoms is usually myxedema. Remember, hyperthyroids have pretibial myxedema. These patients have generalized myxedema. They develop periorbital puffiness, rough skin, expressionless face, and it is usually due to hyaluronic acid. Okay. Now, for the diagnosis, this axis right here is actually well regulated. So if you have a low thyroid hormone, then your TSH is going to elevate because there's nothing inhibiting this response. And so your TSH is going up. And this one right here is pretty specific. If you have these symptoms, you perform a TSH and it is elevated, you have your diagnosis. You may not be required to get the free thyroid hormone levels. So keep this TSH specific caveat in mind for this diagnosis in these patients. For secondary and tertiary causes, then you need to follow all the axes. If you have a low TSH and low hormone, then you have to review the other hormones involved in these hypothalamus and pituitary organs. And for the primary, remember we have in the thyroiditis section fully described which are the anti-immunoglobulins that these patients develop. Now for the treatment, pretty straightforward, replace the hormone, levothyroxine being the used one. It is usually performed gradually, usually in a period of over 6 months. You need to follow the TSH to see the response of the hormone. And that is if you have a primary condition, because if you have a secondary or tertiary, then you follow with T4 for secondary and tertiary, okay? You need to follow with T4. For primary, you follow with TSH. You make it gradually, because if you overstimulate with thyroid hormone the patient, if this patient has aggravating conditions such as arrhythmia or congestive heart failure or any other condition, it may be exacerbated. So you want to do it gradually, following the TSH, right? Now, if you suspect that the patient has panhypopit, then the first thing you need to do is replace cortisol. You don't want to aggravate these patients, leading them into a adrenal crisis, right? And during pregnancy, remember that you need to increase the dose. We mentioned this in regards to the thyroid binding globulins, right? They increase during pregnancy and during elevated estrogen states. So you need to increase the dose in order for you to keep up with the elevation of the thyroid binding globulins, and check the TSH in the first weeks of the pregnancy and throughout pregnancy to see your response, okay? Okay, so to finish this video, we're going to go through myxedema coma. And as for hyperthyroidism, we have thyroid storm. We have myxedema coma for hypothyroidism. It is an abrupt loss of brain function, as a result of severe long-standing hypothyroidism, and it has a huge mortality rate. I think it is around 40%. And now the risk factors is most commonly seen in elderly patients. that are undertreated for their hypothyroidism or inadequately treated. And they usually have a trigger. So prolonged cold exposure is usually seen, infection, surgery, trauma, myocardial infarction is also seen, pulmonary embolism, stroke, for example, hemorrhage, CNS depressants, opioids or benzodiazepines can trigger this for a mixed edema coma development. The patients develop progressive stupor and they lately develop coma, hypothermia, bradycardia, respiratory depression with the CO2 retention, hypoglycemia, they may develop SIADH, for example, and hypocortisolism. And these patients, remember, they have a huge mortality rate. Now, for the treatment, you need to replace high doses of T4 and T3 and supportive therapy for the clinical findings previously exposed. So remember, this is an over-exaggeration of the hypothyroid state, usually seen in elderly patients with these associated triggers, and it has a huge mortality rate, gives supportive therapy, and high doses of thyroid hormone. That's going to be for the video.